So whoever wants to kick it off.
All right, we'll go. We'll start. I'm Rachel Sotsky. I graduated the same year as Dr. Chen, which is, 2018 or 2008. I went to I was a resident at Robert Wood. Then I did my fellowship in trauma at Hershey. And then I practiced for 5 years, private practice in New Jersey. And I moved down to Hopkins 2 years ago. And I've been the orthopedic trauma surgeon down here, one of the orthopedic trauma surgeons down here for the last 2 years.
All right, I'll follow that up then. I'm Antonia Chen. I also graduated the same year. So it's nice to have a little mini reunion. So don't piss off your classmates. Know that you will always be in touch with them and that you will cross paths again. I'm a hip and knee arthroplasty surgeon. After Brigham, I'm at Brigham right now, Brigham Women's Hospital. After Robert Wood, I went to Pitt for residency and went to Rothman/Jefferson for fellowship, stayed on there and practiced for 3.5 years. I've been practicing here for almost 4 years in Boston.
I'm Natalie Dana. I graduated from Robert Wood in 2011. I did residency at NYU Hospital for Joint Diseases. I did fellowship in foot and ankle at Baylor. And then I moved to Maryland to work on faculty at the University of Maryland. And that is where I am currently.
I'm Erin Hancharik. I graduated med school in 2014 and then stayed at Robert Wood for residency, graduated in 2019. So Rachel was a 5 when I was a third year med student. We'll also get back how the world is very, very small. I then did my peds ortho fellowship at Texas Scottish Rite in Dallas. And then with COVID had a little bit of a circuitous route. So I actually stayed on at Scottish Rite for about 5 months as sort of junior faculty, and then did some additional training in limb deformity and reconstruction, which is sort of my particular interest. So I just started also at Hopkins. So we've come back together for peds ortho.
Hi, I'm Jules Forlizzi. Can everyone hear me okay? Great. I graduated med school a year after Erin, so in 2015. Just finished residency 2020 at Robert Wood as well. And then did my sports fellowship at New England Baptist Hospital in Boston. And I just started at a private practice. I will be doing sports, some joints as well. And I'm literally a month into being an attending. So if you have early practice questions and growing pain questions, I'm your girl.
Hi, I'm Zena. I graduated Robert Wood in 2019, and I'm currently a third year resident at the Harvard Combined Program.
All right, thank you everyone for the introductions. We're really excited to have you and have this event. And we didn't have one like this last year, so it's great to see so many different faces and people from all over. So one of the first questions I want to ask, and this is whoever wants to take it, we can have maybe 2 or 3 people bounce off each other for each question. So the first question we got was, during your residency program, how many of your orthopedic peers were female, and did you ever experience any difficulties in your career as a result of being female?
Well, you can all tell Dr. Chen and I were the only 2 females in our class who went into ortho. So we were 2, I think, of 10 who applied that year. So it was 2 of us. Orthopedics was a little harsher back then, I would say. I think it's gotten a lot better with being a female, but it was a little bit harsher. And during the interview process, I did get asked a lot of questions that you are not allowed to be asked, and you will not be asked anymore. There wasn't much guidance when we were in med school. There was one female attending who had just come back as we were going out into the world. And so that was Dr. Harnley, had just started when we left. And then Dr. Balicka actually was a resident the year after me. So it was the first time ever that Robert Wood had 2 females in the program at the same time. And before, I was the 4th ever in the 30-year history of Robert Wood. And Dr. Harnley was the one before me, and she had been, I guess, 6 years prior to me coming is when she had done residency. So there was huge gaps between females at Robert Wood. So I think it's changed because, as you can see, myself, Dr. Chen, but then Dr. Huncharik went to Robert Wood. So we've had a lot more females since I left. So it's definitely become more prominent.
Yeah, and there was one in between me and Dr. Sotsky, and then Jules was a year after me, and then there's another female who's a second year now. You would know better. Third year? Okay. They've only been gone for like 2 years, and I feel like I lost everything. But yeah, I would definitely agree. I was the only female in my mid-school class that applied. But I think overall, I didn't really feel any difficulty being a woman. If anything, I sort of felt like sometimes it was an advantage because it was sort of like, oh, let's see if she can do this. So then I felt like I was able to actually do more early on. The only place that I had issues was actually with other specialties. Like I can remember sort of an ER doctor not thinking I could reduce a total hip dislocation, which caused a little bit of a stir in the ER, but never really felt anything from like the orthopedic side.
And so my background with women is very similar. When Rachel and I were here, there were no females in the residency, and it was very obvious by the call room that was the case, that it was all males in the call room. There were select pictures and magazines. We'll just leave it at that. So I got to residency, and my class was very unusual. It never happened in the history of Pitt. I don't think it's happened since, where we had out of 8 residents, 5 were female. And so I remember going through the list and being, well, Diane has to be a guy, or Sarah has to be a guy, Lisa has to be a guy. And I mean, all the names for the girls were like very obvious girl names. And so it was majority women in my class, which was unusual. And it was an interesting mix because it's not what you expect in orthopedics, but you'll probably notice from the women in ortho here that they're pretty cool and down to earth. So I enjoy working with them. I don't think I'd do as well in OBGYN potentially, but definitely in ortho works out pretty nicely. And Dr. Fu, who was the chair at the time, made it a personal mission to, try to diversify our classes. And it was actually really good in a way because, we go on some rotations and sometimes one of the guys would be like, oh, thank goodness you're on this rotation because I know you're going to work hard. So that was one of those things where it said, can you rise to the challenge of being not the, what we call stereotypical gender when it comes to orthopedics, but in our class, the guys would joke all the time that they were the minorities and we were the majorities. So that was one of those fun things that we could enjoy. But, in terms of experiencing things, I think most of the questioning probably, as you said, comes more outside of ortho than inside ortho itself. But even during ortho itself, they might ask, I would say like, oh, how hard is your grip strength? So I went back home and started working on my grip strength. So it's one of those things where I feel like, at least when I was a resident, I was lucky in a lot of ways that they would make fun of men and women similarly, right? They would say, oh, you're weak. They would say it to the guys too. They would say it to the women. So it'd be like an equal opportunity. Let's make everyone stronger so that you can actually do a good job during surgery when needed. So that in that case was actually a very good setup.
But on that note, you guys can ask when you rotate at Robert Wood, Dr. Harwood, who broke the most mallets as a resident? It was me. I broke 7 mallets as a resident because I hit the hips in too hard. So no guy broke 7 mallets. So
I'm just going to echo Erin because I followed in her footsteps, obviously through med school and then residency as well. I think if anyone has it in their mind that it's a disadvantage, just try to get that mindset out of your head before you apply to ortho, because people can smell fear. And if you look at it as an advantage, I think you have tremendous potential to be seen as hardworking, like Dr. Chen said, because people know that we have a little bit of attention, a better attention to detail, and we remember things about our patients. And that gets picked up really fast. So if you go in with a mindset that I'm going to be maybe not quite as physically strong, but I'm just going to attack this, which is as much hard work as I can, you get noticed for that earlier than the guys, I think, and that can be a big advantage.
I said this yesterday. There were like 2 women in the OR with me, and I think 1 male med student. And I told the women, I was like, female orthopedists are actually better because we're not as strong. So we have to use our brains to do things. So we actually do them in a more appropriate manner. And I told the med student, I was like, no offense, but I think that can be very true a lot of the times.
Yes, there was one of my attendings, female attendings from residency, would echo one of her attendings from residency who said, if I need brute strength, I'll go find a brute. So it's not always, I mean, I'm not saying that, women are less strong than men, but if strength is a concern of yours, it's not, you can use your brain instead of your muscles. It's not a big deal in my experience.
All right, so then on that thread, the next question is, how were there any difficulties in finding mentors in a male dominated field? And then what do you recommend that we do in response to that challenge?
So I would like to look at mentorship at a few things. So there's mentorship, there's like a coaching, and then there's sponsorship, right? They talk about these different realms in it. So a mentor is someone that you can look up to, ask questions from, and they can hopefully give you good advice. And my best mentor actually came from Robert Wood. He just stopped practicing not too long ago, but Dr. Freddie Tria was over at St. Peter's, and I happened to meet up with him and do research with him just totally by accident. I had approached Dr. Gatt and Dr. Dummer. I was like, hey, I'd like to do research with you guys. And they said, we've taken like 2 medical students. And last week, 2 medical students came up to us so that they're full. So everyone says you need to do research between your first and second year of med school. It's been nice now because there's a lot more variety that you can do. But I ended up finding Dr. Tria through another means. And he goes like, I don't normally work with students, but I'll take a chance with you. So I did one project. That's all I did during my medical school time. I feel now you guys have to do like a lot more than we did, I think. But he was a mentor because he encouraged me. He said, this is what I do, and took me to the operating room, let me be in the operating room, be in clinic, watch people do really well after knee replacement. So that's why I decided I want to be an arthroplasty surgeon, not because of my residency. And it was all from my medical school experience. Mentorship is nice because they actually help build you up. Sponsorship is another thing when they actually sponsor you and like nominate you for stuff. So, make phone calls for you, do things like that. They can be the one and the same person sometimes, but they can be different people as well. And I also want to say it's okay to have males as mentors because there's just more males than there are females. So most of my mentors are probably male. I have found one of my mentors who I consider a good friend, going on the vein of when we say we look at our patients, we want to find someone who's like us. So she happens to be an Asian female in arthroplasty, which is not a lot of us in the nation. She's in her late 50s and she's been through a lot. She's been through private practice. She's in the academic. She's been through more of a government kind of system. So I've been able to ask her questions about life and about consulting and about, balancing and things like that. So that's been really helpful too.
I think when it comes to mentorship, it's really important to find your own mentors. I think if you wait for someone to come to you and decide to mentor you, you will be waiting for a long time. I think just deciding that you're going to identify a person that you would like to be your mentor, and then approaching that person is, really the way to go. And so, then it doesn't matter if your mentors are male, female. I mean, I would agree with what Dr. Chen said. There's more males around, so they're most likely going to be your mentors. My experience, especially in residency, was some of my classmates were finding mentors because they were, talking about sports or something that some interest that they had in common with their attending that I didn't necessarily have. And, sort of starting your mentorship relationship that way is easy. But if you don't have that, you just find something else and identify someone who can be your mentor and get after it, just like everything else. I mean, if you want to go into a specialty that you have to be competitive for, you're already used to taking the initiative. So I think mentorship is no different. And it is a really important thing. It's not something that you can gloss over. It's important to have good mentors as early as possible.
And to echo that, you don't have to per se choose a mentor that's at your program. You can go look and find people. All of our emails are out there, especially us in academics. But even, us agreeing to do this, I know there is the listserv of us having our emails. You can find any of us. So a mentor doesn't have to be a person that you actually train with. You can call or email any of us, tell us, say something that you want to talk to us, and, get a mentor that way. So I think that kind of has expanded over the years since, Dr. Chen and I were med students and residents. That wasn't just a freely thing. And there weren't that. So there are more females out. And look, like right now, we have the first female ortho trauma team at Johns Hopkins officially. So my new colleague started a month ago. She's new in practice, and there's 2 females running all of orthopedic trauma at Johns Hopkins Bayview. So it's becoming more prominent. I can't say that would happen before. In my training, I was lucky enough in fellowship to have a female surgeon, Dr. Copeland, who did ortho in a time when she was the only female. So, we all get lucky that you can find some, but now we're available to be reached.
All right, and the next question would be, it's a little more general, but why each of you chose to specialize in ortho versus other surgeries, and then your subspecialty, if you have one.
So I can tell you all that I went to med school and I said I absolutely was not going to be an orthopedic surgeon. I did not have to study because I was not going to be an orthopedic surgeon, because I got injured in high school. I had an ACL tear, and my orthopod told me, you don't need an ACL because you don't play football. So I don't have an ACL on my left knee. And so I went into med school knowing that mentality and didn't want it. And I got thrown into an ortho because anesthesia was full. And all the guys knew that I was going to do it. I just needed the push. And so I went into an elective. And the first day I scrubbed with one of our joint surgeons, and I walked out and said, I'm going to be an orthopedic surgeon. But I had gone in thinking I was going into pediatrics. And, then I did residency, and you just got to keep an open mind. And I went into residency and thought I was going to do arthroplasty, and now I'm a trauma surgeon. So, it's just, and it kind of came from, I went to a conference, and I went to our AO basic. When you're a resident, you go to a basic fracture course. And actually, I gotta say, one of my mentors was one of the women out at Harborview out in University of Washington, Lisa Tatesman, sat right next to me, and she latched on to me and was like, you're going to do trauma. And I'm like, no, I'm not. I'm going to do arthroplasty. And so kind of sitting with her and, going through all of that, I walked out of that saying, I kind of like trauma. So,
So my story is also very, very similar. I came in wanting to do pediatrics as well. My sister had her ACL reconstructed, so it wasn't me, it was my sister, and she brought home a VHS. That does date me, I know. And she goes, do you want to watch this? And I go, no, I have no interest in surgery at all. You can just keep it to yourself. Now I really wish I could see it because I want to watch that video, but I have nothing to watch it on, unfortunately. So after going through that, I remember doing my, so this is back when we were in anatomy lab. Normally when they taught the hand, it was, Dr. Seiden or, a bunch of other people, right? But the guy who taught us the hand was actually a hand surgeon. He came in and taught us the hand. I was like, that's really cool. I like how again, we were not very mature. You pull on a finger and, the certain finger would move or a certain tendon would move, and you go, wow, form meets function. And I was like, that's really a neat way to go. I think I might be interested in ortho. Total switch. End up working with Dr. Tria, who I, shadowed, and I really love to see his patients go from not walking to walking. And I realized that was my personality, that I wanted things fixed. I wanted to see things change and get better. There's only so much crying I could deal with, or so much well baby visits, or so much where does it hurt and they just cry, right? Versus, a patient who has diabetes or hypertension. So I found that the medicine aspect of things was not great for my personality. And then I did a process of elimination. I actually liked my general surgery rotation, as probably you guys will as well. I like being in the OR. I didn't mind if it was a long case, and it was just fun to be in the OR. So I knew that the OR was right. And they say, try to do everything but surgery if you can help it. But if you need to, you do surgery. So I remember going through general surgery, and I was like, well, it's not the environment I wanted all the time. I didn't want to do trauma. No offense, Rachel. So I was like, I want something more elective. Vascular, the sutures were 10-0 and tiny and wore loops. They were totally out. Urology, I didn't want people dropping their pants in front of me at all times. Neurosurgery, I didn't like the brain. It was too confusing and too much. Same thing with the heart and thoracic area, out for me. So I just kind of went down the list of all the surgical subspecialties and was like, nope, not interested in any of them. Within ortho itself, I like to see big things. I like to see open areas. So I was between spine, and Zena will know this well because there's a big spine phenomenon here at H Corp where everyone goes into spine, because our chair here at Brigham is really good about encouraging people to do so. He was also at Pitt when I was there, so I came this close to becoming a spine doctor, but I also realized you still need to use loops and a microscope. So I was like, that's out. And also patient outcomes, not so great. So anything with loops or microscope out. So there went hand. I wanted to operate within elective more part of the body. I didn't understand the shoulder well, still don't. Upper extremity went out the window. And so I was down to foot and ankle and arthroplasty. Tumor, I don't have the personality for it. It's very hard for me. I feel like it's a very sad environment, but the people who do a very good job of it. So I didn't like stinky feet, so that went out the window. So hip and knee replacements became my subspecialty.
I had somewhat of a similar thing when you were talking about anatomy lab. I also went into med school thinking I was going to do psychiatry, but I knew I wanted to do something PD related. But then anatomy lab was like the same exact story of seeing that I could see what or understand what was going on inside the body by doing a physical exam or by understanding sort of anatomy. And I thought that was fascinating. And so that's when I started thinking orthopedics. I never really considered any other form of surgery. So it was sort of, yep, I'm going to do orthopedics. And then again, because I sort of assumed I was going to do something PD related, I went into residency thinking peds ortho, although I did consider hand for a little bit as well. I think with both of those, you can do sort of a wide variety of procedures. You can do soft tissue, you can do bony, hand, upper extremity, you can do some scoping as well, which I don't really do for on the PD side of things. And I just like that you had sort of a bigger range of what you're operating on. Ultimately for peds, I really enjoy working with kids. I think I like the idea that I can have a really big outcome or effect on the rest of their life going forward. And I actually like sort of the long-term process of getting to know kids and following them for long periods of time, versus sort of just like meet them, do the surgery, and then you see them for follow-up and sort of that's it. So I kind of like that longer relationship that you build with them a little bit more. And again, I can kind of operate all over the body still, although I don't do spine within peds ortho. Because again, no, thank you.
I came into med school with kind of vague ortho experience, so I was interested a little early on. I had done a little research before med school, and then knew that I really wanted to be in the operating room early on. And I think a lot of us have had the same anatomy experience of the extremities just being very cool and much more interesting, at least to me, than anything in the trunk or abdomen. So I, on my other surgical rotations, honestly I really did not like general surgery. I really did not like vascular. I realized that I really liked the operative kind of skill set that you use in orthopedics. It felt like carpentry. It felt like it's something that I could understand. You see something and you fix it. So I really loved that early on, and really didn't want to go into anything else. And thankfully it matched, because I know it's getting much more competitive year after year. Even looking now at some of the applicants, it's kind of crazy how much and how quickly things change. And through residency, I've really liked every rotation. I'm the most junior person here, but for every rotation that I go through, I've kind of thought that maybe that's what I want to go into. I'm currently, I think, mostly settled on going into hand surgery, although also kind of thinking shoulder and elbow. Dr. Chen is shaking her head. She's on a personal mission to get all of the women in our program to go into arthroplasty.
And I'm losing a battle because our hand girls are really good.
Everyone's going into spine and now hand.
Hand weenie. Don't do it. Even shoulder elbows, too nerdy. Go do
Wear a bow
sports.
tie if you do hand.
Yeah,
That's
exactly.
tumor, right?
Sitting is really nice though.
True.
Fitting is
I sit in trauma. I do ankle fracture sitting.
So you can sit in foot and ankle for sure.
I did my fibular osteotomy for my Blanz frame today sitting.
I sit because I'm taller than all the male surgeons.
I double step because I'm shorter than everyone else, especially on joints. That was my main double step experience.
But when
Which
you're
honestly,
standing, you can make them sit.
yeah, maybe. I will say though that that was kind of one thing, just going back to an earlier point, that I was fairly intimidated by early on. I'm 5'2", and when I was a med student, the Robert Wood residents were all enormously tall. I remember Erin and Jules were the two female residents at the time, and I saw Erin and was like, oh, there's somebody like a normal size that's here and can operate, and so maybe this is reasonable. And going through residency with some of the very large attendings that I've worked with, I've also thought maybe I wouldn't be strong enough or tall enough, or maybe they'd get annoyed at having to shift around the step stool. But no, honestly, the circulating nurses have been sometimes more likely to say something rude. I've never had a single attending or a single senior resident or fellow say anything about being annoyed at my step stool or having to pull it in or having to reposition the OR table to kind of get a better angle to be able to properly operate.
Now I know everyone said their thing, so I just want to give you the difference in 2 words. Our patients are hurt, not sick, right? I was talking to one of my colleagues today, one of my future partners, and he was like, it's really fun to fix people because they're hurt. Fixing sick is a lot harder, and I have no interest in going to anything else. Also, thank you for pointing out that I am not normal sized. So I am 6'1", and yes, I do tower over a lot of my male colleagues, and they make me very aware of it, and I don't really care. So
if Andy Bowe can operate with Tom McPartland in the same operating room, like anybody will be fine.
And Twasson was also there while I was doing my sub-I and rotations, and there were a wide variety of body types.
Did Twasson ever operate with McPartland?
Yes.
Oh,
Yeah.
that's I would have paid money to see that one.
Yeah. You know, one day there was I think it was like the first magic rod placed in New Jersey. It was Andy, Tom, and Dom. So all 3 of them like hovering over a spine. So you had like a full range going on there.
That's
or for PAOs, they did PAOs together, Dom and Tom.
Hey, anyone operating with Tom McPartland, and I'm going to date myself, Steve Reich and Chaim Blecker. It was like Danny DeVito and Arnold Schwarzenegger in Twins. Steve had 3 stools compared to Chaim Blecker, who had none. So, there you had an attending who had more stools than me.
All right, so moving on to the next question. This is a combination of 2. We got quite a few asking just about the general culture of being in a male-dominated field. So one of them asked about female acceptance and participation in the major orthopedic societies. So like when you go to conferences, and then second part in more social events, like how do you deal with, being the only female when they're planning events in residency, or, planning events for the wives of the orthopedic surgeons, and that doesn't apply to many of us. So what do you do in those sort of settings?
It's awesome when you go to an orthopedic society meeting or even to take your oral boards. The line for the bathroom is amazing. So I brought my significant other to one, and I did not have to wait online. He did. And then at the boards, when they announced that you could go to the bathroom before you go present and do your boards, I didn't have to wait online. The guys all had to think about who had to go to the bathroom within the next 2 minutes. So that's good. But, just they say, be yourself, because if they don't accept you for who you are, then it's not worth it. But, I tend to be a loud person, and, it is what it is, but I crack jokes with them, and I give them the crap that they try to give me back. And so at the end of the day, Yes, I walk into it. I walk into a meeting, especially into the trauma meeting, and there's not many female trauma surgeons, but they do have a luncheon at the OTA for females in ortho. And actually our chairman is a big proponent, just like Freddie Fu. Jim Fickey is a huge proponent of women in ortho, and he's seeking diversity within our department for both attendings. We have, I think, out of our 6 current interns, 6 for our female residents. Last year when I interviewed residents, I only interviewed female applicants. So, and I interviewed, I think, a total of 10 applicants of our pool. And I don't think we only interview 80. So it's a fair amount. Okay. So, it's changing. It's going to change in your lifetime. Me going to a meeting now is totally different than me going to a meeting when I was an intern or a second year. When I went then, I would be the only female. Now, not so much. And you're going to see more females within your attendings. You're going to see more female residents, but then there's also females in your advanced practice providers. So your PAs and your NPs. So orthopedics is growing amongst females at all levels. So.
I'll just echo a small add-on is it's true in arthroplasty as well too. About 2 years ago, we formed the Women in Arthroplasty Committee as part of the American Association of Hip and Knee Surgeons. So the same thing is they're trying to support women and other members too, but specifically this group was formed for women. There's a young arthroplasty group too, which is for young surgeons who are starting in practice. I know they're doing that in trauma as well too. So there's good ways to support people. And same thing we said about mentorship, just reach out to people. People are willing to talk and help and do stuff. I do love the fact that there's no lines for the bathroom. It's one of those things where I'm okay with wearing flat, ugly shoes, and it's okay because it gets me through the conference and no one judges through these things. So it makes for a good combination. And when it comes to residency, again, my residency class was unusual, and that was one of the few classes that had majority women. But I spent a lot of time hanging out with ortho wives, and I will tell you, they're married to a lot of the ortho wives are teachers, kindergarten teachers, because I feel like that's what the age we act, or special ed teachers. So I found that they're very kind and caring people. So I enjoyed hanging out, talking to them. Sometimes I had more in common with them. Sometimes I had less in common with them. And I just think it's just like friends. You'll just find out people who you get along with well. I think that the thing I personally did as a woman is I wanted to make sure that the women felt comfortable hanging out with us and of us hanging out with their, significant others, right? And they would say it all the time, oh, you're just one of the guys. I'm like, yes, 100%. And that was a good thing in my book. I don't think you have to do that. I think you just need to be yourself. I think I'm just one of the guys in general of who I was. I was a tomboy growing up. I think Rachel feels the same way too. But that was okay. So we were being ourselves, and the women felt comfortable around us and the men felt comfortable around us. So that was kind of one of the nice things is navigating. You don't want to make anyone feel jealous or upset because you are spending lots of hours with their significant other. But trust me, you would rather not be if that meant you didn't have to be in the hospital. So it wasn't for fun, it was for work.
Yeah, peds is a little bit different because we definitely have a higher percentage of women. So going to conferences, there's a large, maybe even close to 30+% is women. So it's definitely very different in that respect. But again, all of my mentors are male, and I feel just as comfortable calling them and asking them about questions as I do talking about family things and just sort of general life. I think as everyone's saying, just, you are who you are, and you gravitate towards people that you're going to get along with no matter what. It doesn't matter if they're male, female. And so you just sort of find your group in your job, in residency, at conferences. There's always people to talk to.
I'm just going to add that I had a unique experience in that I played a lot of years of basketball in my life, and I really enjoyed it through med school. So I would play with guys because you can't find 9 other women to play an hour of pickup, and that's just who was at the gym. So I would never, ever get any sort of, I'll just use the word sexist looks or discouragements about my game from the guys who were good, right? So I always used to say game recognized game, like it's a silly thing. But then halfway through my fellowship, Tom Gill, who is one of my closest mentors, he's made some phone calls for me. He's amazing. He was the head team doc for the Pats, Bruins, and the Red Sox for 14 years in Boston. So he's operated on most of those guys. And we're in the middle of a slap chair and like we're passing sutures and I'm doing whatever. And he stops the case to tell me a story. I'm like, okay, Dr. Gill, like we have 6 more to do. Can we get moving? And he's like, I hired the first female fellow at Harvard, like for sports. Like I picked her. She was my pick. And I was like, okay. And he's like, isn't that a good thing? And I was like, that's a great thing. Great game, recognized game. Like, do you want credit for it? Like, was she good? He was like, yeah, she was good. I'm like, okay, let's just keep going, but he had never thought of it like that. Like he was so proud that he picked a woman because she was a woman, but I just thought that she was the best person in that class. And he was like, yeah, she was. So the colleagues that you'll have around you won't notice that you're different if they're at your level, if that makes sense.
In my class in residency, we have, similar to what Dr. Chen had with hers, we have, I think it's the first majority female class in the history of the program. We have, out of 12 residents, 7 of us in my class are women. And I feel like the dynamic, and especially when I was looking at residency programs and going on a ways, I kind of realized it's not about the gender composition of the program. It's really the culture that you kind of decide whether you fit into or not. And there are some programs with more women that I didn't like and I did not feel comfortable. And some programs that were more male dominated that I felt more comfortable in. So it's the culture is not always determined by what everybody looks like. It's really the environment that you go into. And in terms of kind of significant others, I remember when I was interviewing here, there was on our interview dinner night, there was a Better Halves event. There's a Better Halves group where kind of the significant others of the residents have these cute little events. And my husband was the only man in attendance at that pre-interview dinner. And since then, a lot of the other guys have joined the club because we do have a lot of female residents in my program. But I don't know, maybe he has a different perspective, but you kind of meet people that you get along with and you meet your people and you find your crew, regardless of where you are. And you're kind of, as a resident in a program, you kind of help shape the culture. And I think a lot of us have taken that to heart to kind of shape a culture that's welcoming to whoever may come in.
Okay, and moving out of the internal orthopedic culture, but now into societal culture as a whole, how do you balance family life, your profession? I think this goes for being a physician in general, but in a surgical subspecialty, I think it really hits home, and external pressures to be a mother and fit the societal norm in that sense.
I'll start with this. I think work-life balance is an ongoing struggle. I mean, we all, a lot of, most of say we probably all love our jobs and just want to do more, and want to be the best surgeon we can be, right? We're in this for the patients, and it's hard to say no to more work, but I think it comes down to just sort of deciding what you want on your plate. And, things that don't fit those priorities, like they have to go, you have to say no. And it's hard to do that, especially if you just want to take on more. And, if people ask you to be on committees or, do various things that especially come along with academic medicine. But it's just a matter of deciding kind of how you want your time spent, because there are only so many hours in the day. I have 2 little kids. I have an 18-month-old and a 5-month-old. So it is important for me to spend time at home. And there are, you find no matter what your responsibilities are and what directions you're pulled in, there are things that you need to do and there are things that you don't need to do. And, one thing that we are very lucky with as orthopedic surgeons in particular is we can hire out the jobs that we don't need to do, that aren't important to you. So if they're not filling your cup, away it goes. So you can hire out a lot of jobs, especially if you're in a city. And so, when you decide how you want to spend your time and what is important to you, then just find a way to get other people to do the other things. And that's especially important with work-life balance. I mean, you can have your groceries delivered, you can have food cooked in your house can get clean, anything that you want to have happen can happen if you, find someone who can do it for you. So, that helps with work-life balance. I do find, in particular, in orthopedic surgery, and especially in foot and ankle, there is, I wouldn't have thought of it as a lifestyle specialty, but it is. I'm married to a trauma surgeon, not an orthopedic trauma surgeon, general trauma surgeon, and that is not a lifestyle specialty. I can say that. But by comparison, ortho is. I can be home to put my kids to bed, which is very nice. So I think when I was at the level of medical school, I was worried about my ability to balance work and personal life, and it has been less of a concern as I've gone along. So also don't let yourself be kind of scared away from the field for fear that you'll be, only working all the time. And if you want to only work all the time, then definitely do that. You can do that too. There's nothing wrong with that.
And I think to echo on that, there are definitely fields in orthopedics that, a more elective practice, you can balance your work life balance a little bit more. Trauma is hit or miss. When I was a resident, there was a pretty good support system. In my first job, that's kind of why I left. My first job was I was working all the time and there was no balance. And then I came here to Hopkins, and, having a colleague, I have 2 colleagues downtown, and there's 2 of us at our level 2 center, which is actually way busier than our level 1. But, I have colleagues that support me. And so, they know that we all shouldn't be at work all the time. And so, yes, for the hard cases, I have to be there and I have to do the trauma for that, or my colleague who just started. But other than that, they can take care of hip fractures and stuff like that, everyone's trained orthopedics 101 and when you do adult. So, and as Dr. Dennis said, I hire someone to clean my house. I, have my food delivered. Sometimes, you don't have things once you are off the resident salary, things come a little bit easier. You don't have to worry about those things, and you just make decisions about what you want to and what you don't want to do. And it's not just a problem for women. Okay. My trauma colleagues, the male counterparts have the same issue of figuring how to balance seeing their children and being with their family and getting there. And there's going to be times in no matter what field of medicine that you can't be at everything. And you have to make that hard decision. Because, we all worked hard to get where we are. We all want to do more. We all want to be there for our patients, but we all have to find that balance of where we are going to be there or we have to let go and be at home. So.
Go ahead, Dr. Chen.
I was going to throw into the mix just a little bit in terms of it's also going to go into other obligations outside of work, right? So not just family, which we're all bringing up here, not just friends and social life areas, but things like national meetings or local committees and hospital committees. So a million things will be pulling you in all different directions, whether you're an academic or private practice. And it's a matter of saying yes versus no. In the beginning of practice, I tend to probably say a little bit more yes in the beginning. But then as time goes on, you definitely want to start saying no to more things because your time is precious. That's the only, and I was also consulting ideas and things like that with industry. So, time is money in a lot of different ways and time is precious. So know what you want to do and know you do it and stick to it and just kind of saying, will this add to my goal of blank? And then try to keep that mind frame as you're going forward. Because right now when you're in med school, you're like, I just want to graduate. Or if you're in residency, I just want to graduate. And those are good things. You want to do those things. But once you start in the workplace, you can say, okay, how is it? I use this from the joy of tidying up or something like that, right? Does this bring me joy? Is this something that's going to make me happy, or this is going to make me further my X, Y, and Z or reach my goal? If it's not, then say no to it. It'll be hard to say no first because all you said your entire life is yes in medicine. But once you start doing that, then you can start culling things and saying, okay, no, it's important for me to be home when my kids come back from school, or it's important for me to be at this meeting, but then I'll do soccer practice next day or something like that, where you say yes to some things and no to other things.
I'm just going to chime in here because I think I'm unique. I don't want to speak for Zena, but I had a kid during residency, so I don't know if anyone else did. That was fun. So things that you may or may not know about or be afraid to ask about, just email me. Christina has it. There is pregnancy grade lead. I had to buy my own. I lied to everyone and said my back hurt, so I tried to get a 2-piece to see if that would feel better. They didn't figure it out till I was 22 weeks pregnant. There are really good animal studies about cement. I was on my arthroplasty rotation during my first trimester. There's not human studies. I don't think there will be, just because of the way IRBs are, and I'm not sure I'd want human studies, but there are very good animal studies if you choose to do arthroplasty and need to be in a cement room during your pregnancy. I chose to get genetic testing on our baby. Everything's fine. She's 20 months old. You might hear her screaming downstairs. It's bedtime. If you have questions, the interventional radiology literature is a lot better than the orthopedic literature. So if you choose to do your own research, there are more women in interventional radiology. The orthopedic literature is more studies need to be done on the effects of fetal whatever. I handled my maternity leave in a way with my co-residents. We were unique. We only had 3 people in our class. So I had 2 male classmates. I told them really early, as compared to everyone else who literally took, like, Dr. Butler's kid asked me at 30 weeks if I was pregnant. I was like, yes, we are well into this. But I told my 2 classmates early. I felt comfortable telling them. And I was like, we're going to come up with a plan. So I ended up using just my vacation time. I didn't take any extra maternity leave. Every program is going to have a different outlook on that. Like Zena said, look at their culture for how they will support you. And 3 weeks of call missing is a lot different when you have a kid at home. And then the way I handled job interviews, I didn't wait for them to ask. Maybe that's just my personality. I just said, I have a baby and we're going to have more babies. And if you have a problem with that, I didn't actually say this part. If you have a problem with that, maybe I'm not your person, but that was the next inference. So I just made it clear because I didn't want questions, and I put it on me. I said, yeah, I'm a mom and I have a husband who's the absolute best. He's actually watching our kid right now while I'm on here. And if anyone has any questions about navigating pregnancy and residency, shoot me an email. I understand it's a sensitive topic. It's something that worked for our family. It doesn't work for everyone. So I was a chief spring, took 3 weeks leave. That's not enough. Take more if you can. It was not enough. During fellowship, we had childcare because we were near my in-laws. And now we're figuring out childcare that I'm attending, and the budget has changed a little bit.
Yeah, I would just say that definitely you want to have a balance and figure out what you need. But I remember my concern sort of med school and early residency when I was single at the time, and just worried like, oh, am I going to be able to find somebody that understands my lifestyle? And so I don't know if anyone else has sort of those concerns. But the thing is, when you find someone who is like actually right for you, they love you because that's who you are. And that's the type of person that you are. And so that's my husband currently. He is like the most supportive of what I want to do, understanding, we've been apart for 2 years at this point, doing long distance. And it's solely because of my career and what I want to do and getting the training that I feel like I need to do to take the best care that I can of my patients. And he totally gets that. I just started at Hopkins, so he's still applying for jobs down here, and he turned down a job because the hours were going to be too long. And he understands that one of us needs to have a somewhat relative lifestyle, and that's not going to be me. And so he's going to look for a job where his hours and lifestyle going to be more normal so that he can pick up the kids from school and he can make dinner and sort of do those things. And so I think finding a partner like that is such a huge, amazing thing to have as well. So that just kind of gets rid of another area of stress too.
One of the pieces of advice that I got that at least so far has appeared to be true looking at some attendings is to not make your specialty decision based on what you think the lifestyle might be, because things change and residency is not the rest of your life, because residency has been very hard and it is a very tough lifestyle to be in a surgical residency compared to your friends in other fields aside from general surgery. They get you. I think that seeing a lot of our faculty, it does appear to get better, and there are so many different choices that you can make when you do apply for jobs, whether you're going into private practice or academics, that you can kind of pick something that works. And honestly, even within residency, elective surgery rotations are very nice. Today I got out of the OR after 4 cases at 2:30 p.m. We went out for a team lunch and I was home by before 4. Definitely not always the case. There's a lot of call, and that can be tough on you and your partner and your family. We have a dog. We don't have children, but dog care is also a little more challenging on a residency schedule. You spend more money on a walker. But I think kind of looking back, if I was more worried about the lifestyle and went into something else, I would be really disappointed because I absolutely love operating in orthopedics. It gets going on OR days, gets me through a lot of the hard call days. And I think that is kind of indicative of being where you want to be. And so even through these first hard few years of residency, I don't regret going into the specialty, and I think it does get better. The other people on the call can maybe confirm or deny.
It gets better. And, at the end of the day, you have to do what is going to make you happy. If you hate going to work every day, you're not going to love it every day. But if you despise going to work, you're not going to be able to do it, especially in orthopedics, because it is hard. Your residency is going to be the 5 probably hardest years of your life because you're going to be working. You need to learn orthopedics so that you can be a surgeon. So it gets better. A lot of days I do complain, but at the end of the day, I underlyingly love my job. And so I couldn't do it you can't do it if you don't.
It's so much better. I want to echo that because it's huge. I loved residency, but it was hard. It was really, really hard. And there was a lot of time that I thought, even loving orthopedics, I don't know if this is going to be worth it in the end. And my first couple months in practice, I already felt like it was worth it. All I really wanted was to love my job and then be able to go to like the post office if I needed to during business hours. And by the time you're attending, you can do that once in a while if you need to, because you're in charge of yourself and your own time. And it really ends up being worth it. It gets better.
That's just something I worry about even later on, but in terms of employment models and things like that, some practices you need to ask for like weeks in advance to take a day off. Some you can just block it the day before. So those are things to look at too in the future, but they do look at balance, and some specialties go into that area as well too. So lots of different options, and you can kind of cull things where you want to. There's a colleague that I know from Philadelphia. They're both orthopedic surgeons. She decided she wanted to spend more time with the kids, so she's part-time ortho, and that's also a possibility as well. So there's a lot out there, and don't feel like you get pigeonholed into one area.
Well, I think that brings us to an end, and it was a good point to end on that. Things do improve after all of this training. But thank you all so much. Again, if anyone has any follow-up questions that we didn't cover, you can email me. I could pass along the appropriate contact info, but we're really appreciative of your time and coming back to talk to us. So thank you guys so much.
Thanks so much. Good job organizing.
Thank you.
Have a good night, everyone.
Thanks. All right, bye.